Dr. Rossing on the stage, and he will talk about the impact of GLP-1 receptor agonists and SGLT2 inhibitors on CKD progression in subjects with diabetes. Peter, please.
Well, thank you very much. I promised I'll be back, and here I am. I hope you enjoyed the break, and at least there was a lot of good talk and interaction outside. That's what these meetings are about. It's the breaks and all the interaction, but hopefully also here during the sessions we can provide some interesting information. And in the morning we talked about SGLT2 and I talked about obesity, a little bit about GLP-1, and in this session I'll talk more about GLP-1 and SGLT2, focusing on what we know from diabetes and kidney disease, and talking a little bit also about mechanisms, or what we think are the mechanisms of these drugs, because there are many ideas and probably we still have a lot to learn on that aspect. And here are again my disclosures, and you saw them before, so I'll move on. And just before going into this, reminding all of you, and it shouldn't be a surprise, but kidney disease and diabetes is not only prevalent, as we discussed in the previous session, but it's also serious and has implications for length of life. So this is lost life if you have kidney disease or if you have diabetes, 6 to 10 years, and then if you have the combination, well, it's 16 years of lost life if you're a young person with diabetes and chronic kidney disease. So it is not only prevalent, it's also serious, impacting quality of life and length of life. And we alluded a little bit to it in the previous session. That means we need to start early. We need to identify those with kidney disease. And Beatrice mentioned that early intervention gives much better benefit. So if we wait until there are symptoms, that's, I wouldn't say too late, because there's probably never too late, but there is much more to gain if we start early. So we need to screen, and I assume most of you are nephrologists, so you'll know to look for proteinuria and GFR and then implement the treatment opportunities. But your colleagues, the GPs, and maybe the endocrinologists like me, are not that well in doing so. So please help me in spreading that message to all your colleagues in general practice, because they are seeing the majority of these patients when treatment should be initiated. So this is super important. And going to data from the US, and they are almost identical in Denmark, unfortunately, but that is that everybody has a regular test of kidney function using creatinine if you have diabetes and are followed in an outpatient clinic. So 95% have a yearly estimation of kidney function. And that's to the left on this graph. But to the right, you can see that only 50%, so only half, have an evaluation of proteinuria. And this is important because proteinuria is the entry criteria for many of the trials and indicates a high risk for progression, as you will of course know. So we need to improve that. And in Denmark, we are a bit higher than that. And I know in Sweden, in the National Diabetes Registry here, it's also a bit better than this. But in general practice, screening for kidney disease is not optimal. And for many years, people thought, well, we have RAS blockade, so that's fine. They are treated for hypertension. But now we have treatment opportunities that we can add. So we need to screen for kidney disease. And if you're a nephrologist, you see the patients late in this course, but you need to educate your colleagues. Now, as we heard earlier, kind of many years ago, there were no opportunities, but now we have different opportunities, and we have talked about SGLT2 inhibition, GLP-1 receptor agonists, and I briefly mentioned the non-steroidal mineralocorticoid receptor antagonists in addition to the RAS blockade. And the beauty of these different opportunities is that they can target progression of kidney disease in different ways. So this is from a review recently, or last year in October, I think it was, by George Bakris and his colleagues, describing that kidney disease and diabetes is driven by metabolic factors, hemodynamic factors, and inflammation, all causing fibrosis and loss of kidney function. And we can intervene in the metabolic pathways regulating glucose. We can intervene in the hemodynamic perturbations with RAS intervention, inflammation maybe with the mineralocorticoid receptor antagonist or aldosterone antagonism in different ways. And you can say maybe SGLT2, GLP-1 also has other effects than strictly the metabolic effects, sure, at least in experimental models. And this data we have so far would suggest that actually we can target the progression of kidney disease with these different agents in different ways. Now, coming to the SGLT2 inhibitors, it was here in Stockholm several years ago that the EMPEREC trial was presented, and that these data were demonstrated, showing that there is a significant reduction in not only the cardiovascular outcome, which was the primary focus, but that empagliflozin also reduced progression of kidney disease. And I think I was not involved, but I think kidney outcomes were number 13 on the list of interesting outcomes they could look at. So they had no idea that this was a kidney drug. And I was involved with SGLT2 inhibitors initially because they were kidney toxic. It was supposed, or we were concerned, because flushing glucose through the kidneys would probably not be good. And then came these data showing up to 50% reduction in different kidney endpoints, and people say this is a mistake. It's just because it's not a kidney trial. They didn't evaluate it right, and FDA declined their claim because there were all kinds of issues, and they were not repeatedly tested and so on. So this was obviously considered to be, this can't be true. But of course, as you know, as time has passed, more cardiovascular outcome trials in type 2 diabetes demonstrated same findings, and then came the dedicated kidney trials in diabetes and also, as we heard before, in non-diabetic or mixed CKD. And Credence, illustrated here, was the first showing that canagliflozin reduced progression of kidney disease with 30% in type 2 diabetes with proteinuria or albuminuria above 300 milligrams. So this was a major kidney benefit on top of RAS blockade demonstrated with an SGLT2 inhibitor in diabetes. So this was after many years of different trials that really didn't go very well and was stopped either for side effects or lack of effects. We suddenly, a bit surprising, had a new class of drugs that showed benefit in kidney disease and diabetes on top of the RAS blockade that had been standard of care. And together with Hiro, who is going to speak after me, I was involved in DAPA-CKD, where we took this one step further and went from diabetic kidney disease. We lowered the entry criteria for albuminuria a bit. We lowered the criteria for eGFR a bit. And then maybe most important, included as well non-diabetic kidney disease in this study. And as you will, of course, know, this study was also positive, showing that, again, there was this benefit of an SGLT2 inhibitor on progression of kidney disease. And this composite endpoint, including cardiovascular death, as well as progression of kidney disease. So 40% reduction, and the numbers needed to treat of only 19. That's really significant outcome, and impressive and really important. Coming back to what Beatrice said, we really need to ensure that patients are treated with this to get the maximal benefit as early as possible. And what was interesting and very unexpected or unknown, I wouldn't say unexpected, but unknown when we started the trial, was what would be the benefit in those without diabetes. And this analysis demonstrated from DAPA-CKD that it was independent of diabetes or not, meaning that the benefit on both the primary outcome or the other outcomes were completely independent of having diabetes. So this is subgroups based on diabetes, based on albuminuria, or based on eGFR, showing consistent benefits. And if you look at more advanced kidney disease compared to early kidney disease, well, you can see again there was a consistent benefit. So as I said before, it's never too late. Even in stage 4 there was a benefit, but also in early disease there was a significant benefit. Then many of my colleagues, endocrinologists, they were concerned in stage 4 when you have a GFR below 30 and you are concerned of this initial dip in kidney function, could we then start an SGLT2 inhibitor? So it was encouraging to see that the SGLT2 inhibitors, yes, reduce GFR a little bit initially, but if you have a low kidney function, this dip is smaller. So you shouldn't be concerned about pushing people into dialysis. And in the previous discussion session, we had a question about what will you do to mortality with the SGLT2 inhibitors if you have kidney failure, and that has not really been tested. But in DAPA-CKD, we were able to demonstrate a reduction in all-cause mortality in this population with the SGLT2 inhibitor. So really important outcome benefits, cardiovascular benefit, kidney benefits, and mortality benefits. Then you can say, how early is early? And Beatrice gave you should say, start very early. This is a meta-analysis of different trials, and there has been a different meta-analysis. But the main point here is that the relative benefit is the same whether you have normal kidney function, if you have moderately impaired kidney function, or if you have more advanced kidney impairment. Then in all these strata, there is a benefit on progression of kidney disease to hard kidney outcomes, suggesting that, of course, there's a benefit late, but there's also a benefit if you start early, to the point that Beatrice made earlier. And you can say, well, this is about GFR. What about different strata of albuminuria? So there was also it looked at whether you had severely increased albuminuria, moderately increased albuminuria, or normal albuminuria, as was also discussed from the EMPA-KIDNEY trial before by Natalie. But in line with what Natalie was discussing, then there is the same relative benefit in all these strata: normal, moderately increased, or severely increased albuminuria. Now, the relative benefit is the same. The absolute benefit is not the same, because if you have more albuminuria, you have a higher risk, and therefore you can say the absolute benefit is higher if you have a high risk and you have the same relative benefit. So this is not to confuse you that I talk about relative and absolute risk, but it's just to say that there is a benefit for everybody, but it's particularly much to gain if we start late, because then the absolute benefit is good. But on the other hand, as Beatrice talked about, starting early give you a long time to see a benefit and a long time to accrue benefit, and therefore that is also important. And the different trials, you could say, in the KDIGO heat map looks like this. So initially we started with credence and DAPA-CKD with increased proteinuria, and EMPA-KIDNEY, as we heard about, took it down to normal albuminuria with impaired kidney function. But if you take the cardiovascular outcome trials and the heart failure trials and look at the diabetes populations, then we actually have also in the normal albuminuric patients with GFR less than 60 and also above 60, as I demonstrated before, indications that there is a benefit. And that's why the claim for use of SGLT2 inhibitors in diabetes is not only in those with proteinuria, although those are the ones with the highest risk and therefore the most absolute benefit. And we saw the SMART-C meta-analysis before that looked at all these trials, put them together, and saw that there was a benefit across the different populations, and that was independent of having diabetes. So I'll not go in details with that. But then I'll discuss how can it be that the SGLT2 inhibitors work so well, now that we actually thought they were going to damage the kidneys, but actually did benefit to the kidney. And I guess the short answer is we don't know for sure. The more sophisticated answer is that there are at least 6, 8, 10 different theories about how it can be that SGLT2 inhibitors work. And one of the popular initial theories was that you reduce the intraglomerular pressure like we know it from blocking the renin-angiotensin system, which can also explain this initial dip in GFR when you start an SGLT2 inhibitor, and that this relates to blocking of uptake of sodium and glucose in the proximal tubule, and then leading to distal feedback, tubuloglomerular feedback, when sodium is excreted more distally and then reabsorbed and signaling to the macula densa that you should reduce intraglomerular pressure. So in that sense, this could be an important part of the mechanism of action, and could also explain why it's not related to glucose, because it may be related to sodium and sodium reabsorption. Could also be that, at least in diabetes, where there is an effect on blood glucose levels when you have at least moderately to preserved kidney function. We know hyperglycemia is not good for the kidney in diabetes, so therefore that may contribute as well. We also know there is an effect on blood pressure. There is an effect on obesity. It is not as big as for the GLP-1 receptor agonists, but there is an effect, and there has been suggested an effect on vascular stiffness, an effect as you could say a diuretic, and then there has also been suggestions that there are metabolic effects, increasing ketone levels that could be good for kidney and heart. And also other theories that I'll not come into, increase in hemoglobin and so on. But I'll give one additional explanation, which is about hypoxia. And a good colleague suggested that absorbing or the transport of glucose and sodium in the proximal tubular system is one of the most energy requiring processes in the kidney. So when you block that process, maybe that contributes to, you could say, saving oxygen, saving energy for the kidney, and maybe that could be beneficial. And there has been different studies trying to evaluate this. We did a study which was a short-term study in type 1 diabetes, where we gave a single dose of an SGLT2 inhibitor in a large dose, and then we measured kidney oxygenation in the cortex and in the medulla in these type 1 patients for 6 hours while they were in a magnetic resonance imaging machine. And when oxygenation is improved, then you go down on this scale. The R2 star value, which measures oxygenation, is reduced. So going down means oxygenation is improved, and going up means oxygenation is impaired. And what we saw was actually that with the SGLT2 inhibitor, we could improve oxygenation, particularly in the cortex, a signal which was not statistically significant in the medulla as well. And this was despite having similar kidney function, similar blood glucose levels, similar flow in the kidney and so on, and similar oxygenation in the periphery. So it cannot demonstrate that this is the way that the SGLT2 inhibitors work, but could suggest or is in line with that this oxygenation or energy requirement may be important. So longer studies are needed to test, and some longer studies have found that there may be an effect, and some have said, well, if you block proximal reabsorption, that just leads to more work distally, because then you have to reabsorb the electrolytes more distally. But at least this has also been proposed as one, you could say, potential mechanism. And Jens, who did this study, had this cartoon drawn because he thought SGLT2 inhibitors, they are like the oxygen for the kidneys. So, and they will save the hypoxic kidney by reducing the workload on the kidney. I guess we need more data before we can say this is the mechanism, but maybe it contributes. Now, these data from the different trials led to the guidelines to include SGLT2 inhibitors in diabetes and kidney disease as an important first-line therapy. So if you have diabetes and kidney disease, you need to have SGLT2 inhibition And here metformin is also in the guideline. Maybe that will change going forward, but at least SGLT2 inhibitors was put there, not because of their glucose lowering effect, that's fine, but because of their kidney protective benefit. And then next in line is the GLP-1 receptor agonists, because they may, we know they give cardiovascular protection in those with diabetes and kidney disease. And then the question is, do they also give kidney protection? And I showed you this in the previous session before the break, where I showed you that there is less progression of kidney disease in these trials, but mostly driven by less progression of albuminuria. Now, how could GLP-1 receptor agonists potentially be kidney protective? And well, a little bit like the SGLT2 inhibitors, there are a lot of different mechanisms that have been suggested. There are some effects on glucose, body weight, blood pressure that have been suggested to be able to contribute, at least to some extent. And then there are also, as for the SGLT2 inhibitors, other different mechanisms like effects on inflammation, effects on sodium excretion, effects on oxidative stress and the renin-angiotensin system that may contribute, but mostly have only been demonstrated in experimental settings. And we don't really know. We know there are GLP-1 receptors in the kidney, on the vasculature, but what it's doing, we don't really know. So in that sense, it's still, the jury is out, you can say, for how may the GLP-1 receptor agonists work. And if we look not only on the LEADER and the SUSTAIN trial, but on different trials, cardiovascular outcome trials, what is the benefit on progression of kidney disease? In the top is trials where the outcome includes progression of albuminuria. Here there is a significant 20% reduction in progression of kidney disease. But if you take out albuminuria, then the benefit is a 14% reduction in progression of kidney disease, and it's no longer significant. So that's why we need more data for the GLP-1 receptor agonist. Remember, these are all cardiovascular outcome trials in diabetes, not kidney trials. There was one trial done in a kidney population, the Award 7 trial, testing dulaglutide against insulin as a glucose-lowering agent. So it was not really a kidney outcome trial. It was a trial for glucose efficacy in patients with impaired kidney function with a GFR around 30. And when they looked at progression of kidney disease, there was less progression in those treated with the GLP-1 receptor agonist compared to insulin. But it was not powered as a kidney outcome trial, but there was less decline in eGFR, but you can say still relatively small differences and a relatively short trial for 1 year of duration. So we really needed a kidney outcome trial, and that's why the FLOW trial was designed. And FLOW was a trial in type 2 diabetes with proteinuria, testing if the GLP-1 receptor agonist semaglutide could reduce progression of kidney disease or cardiovascular outcome in these type 2 diabetes patients. And the trial recruited more than 3,300 individuals. And you could say of interest, 15% were already on an SGLT2 inhibitor at baseline, so that will be able to tell us something about the interaction of these two therapies. And the primary outcome was an endpoint of 50% reduction of kidney function or kidney failure or cardiovascular mortality or kidney mortality. And as you are probably aware, then the trial is soon going to be presented. Now, before I come in a little bit more on what is going to happen, the REMODEL trial is a trial that we are involved with that are testing why are the GLP-1 receptor agonists working on the kidney. So now that the FLOW data are coming out and are expected to be positive, you can say it's not if they work on the kidney, it's how they work on the kidney. And this is an interesting study. It's a small mode of action study of approximately 100 patients randomized to semaglutide or placebo for a year, but using all kinds of, you could say, fancy technologies to try to assess how it works. So it uses magnetic resonance imaging to assess flow and oxygenation and so on in the kidney. biomarkers in blood and urine, but also tissue will be interrogated with kidney biopsies in a subgroup, baseline, and at the end of this study. So hopefully this will teach us something about how semaglutide works on the kidney. And we were, of course, very curious to know what the FLOW trial would show. So last year, when we had a steering group meeting, we asked ChatGPT, and ChatGPT predicted. And actually, it was Vlado Perkovic. He asked ChatGPT and 2 other of these chatbots. They all consistently said FLOW is going to be stopped early and will be positive. And that we discussed in September, and we laughed and said these chatbots, they are really crazy. And then, as you know, 1 month later, the trial was actually stopped. And then earlier this year, it was released that the trial reduced the primary endpoint with 24%. It was successful, and it's going to be presented Friday here in Stockholm. What was interesting was also that you could say the secondary outcomes of this trial was also positive. So in that sense, you can say you need to come and hear more Friday because it's really interesting outcomes with this first dedicated kidney outcome trial with a GLP-1 receptor agonist in diabetes. So ending where I started with these different pathways, but now you could say what has been the concept of pillars of therapy, that going forward in diabetic kidney disease and maybe also in chronic kidney disease in general, we should not talk about RAS blockade alone or RAS blockade or SGLT2, but combine RAS blockade, SGLT2 inhibitors, GLP-1 receptor agonist, and non-steroidal mineralocorticoid receptor antagonist to get the optimal benefit. And you can say, of course, a task for the future will be to find out, do everybody need all of these interventions, or what should be the order that we implement these drugs? And can we find a way so that for some people with diabetes and kidney disease, only some of the drugs are needed, and for others, others are needed? And together with Hito, I'm part of a consortium Hito is leading, where we're trying to do personalized medicine. And personalized medicine is about finding out what to do for whom, finding the right drug for the right patient. But maybe we need to give everybody everything. And that's, of course, interesting. But currently the guideline will say that we need in diabetes to start with lifestyle, then add SGLT2 and metformin, RAS blockade and statins to reduce the kidney and cardiovascular risk. We need to use non-steroidal mineralocorticoid receptor antagonist if there's still albuminuria, and the GLP-1 receptor agonists are recommended here for their cardiovascular benefit as a second-line option. But I'm sure that when we have seen the FLOW results, we will have to consider in the different guideline communities, what are we going to do? Are we going to change these, or how are these guidelines going to change? I guess it's not if they will change, it's just how they will change. We will have to wait in the future to see what happens. Before I end, I'll just say, what about type 1 diabetes? These drugs may work as well in type 1 diabetes. So without going into details, I'll just say that we are trying to test, and together with good colleagues, for instance, if several of these compounds will work in type 1 diabetes and cardiovascular and kidney disease. We don't know. Currently, the problem is that they are not used in type 2 diabetes even, where we know they work. So these are data from the US showing that only 20% were treated with a RAS blocker and less than 1% were treated with an SGLT2 inhibitor or a GLP-1 receptor agonist. And you can say, yes, it's not Sweden, it's not Denmark, and it's a couple of years old, so hopefully it has improved, and it's much better here. And also in the US, it did improve a little bit. They reevaluated, and now they are 7%, and other countries have better data. Still, I'm afraid there's a long way to go with implementation. So look for kidney disease. Well, all your patients probably have kidney disease, but tell your colleagues to look for kidney disease. Then treat with lifestyle, with SGLT2, RAS blockade, metformin, and statins, if it's diabetes and kidney disease we're talking about. And then implement the new opportunities where GLP-1 and SGLT2 are important. for kidney and cardiovascular protection, which is super important because of the high risk in these patients. And then we need to consider how we organize care, because the way it's done currently in most places doesn't work. So we have the treatments, but they are not implemented. So with this, thanks a lot for your attention.